Okay, you're seeing a picture of a camel, which is the master of renal function. They can concentrate their urine so much more radically than we can, and I'm sure you always wanted to know that about camels. Okay, the renal system is a system where the kidneys filter the blood to get rid of excessive fluid, waste products, especially urea, creatinine, as well as uric acid, and many drugs, and regulate the body composition of fluids and salts. They're involved in blood pressure control, salt-water balance, vitamin D metabolism. They secrete the hormones renin, which helps control blood pressure, and erythropoietin, which helps produce red blood cells. You'll see that your renal failure patients may be anemic because their kidneys may not be making erythropoietin. Kidneys, excretory organs, the ureters transport urine from the kidneys to the urinary bladder. The urinary bladder is a temporary storage reservoir for urine, and the urethra transports urine out of the body. In this picture, you can see this is your left side here, and your left kidney is superior to your right kidney in the human here. So it's your kidneys, your adrenal gland, this is your ureter, goes down into your urinary bladder, and then the urethra. Okay. Now, functions of kidneys: removal of toxins, wastes, ions, regulation of blood volume, chemical composition, pH, gluconeogenesis, which is glucose, new, genesis, making. So making glucose out of other stuff like protein during prolonged fasting. We've already mentioned renin and erythropoietin. They also activate vitamin D. Physically, the kidneys are retroperitoneal in the superior lumbar region. And here, this we already mentioned, the right kidney inferior to the left. The convex lateral surface and the concave medial surface. The renal hilum leads to the renal sinus. We have ureters, renal blood vessels, lymphatics, and nerves enter at the hilum. Kidneys anatomy have several layers of supporting tissue: renal fascia, perirenal fat, which cushion and help anchor tissues in place, and a fibrous capsule. Here you have a picture of these. This is, of course, the posterior side and the anterior side, and your kidney here. And this is the fibrous capsule. This is a perirenal fat capsule. And then around here we have renal fascia as well. Trying to see where it's labeled. Okay, this is a kidney, an kidney, and of course a drawing. And we have the renal cortex is the outermost part, medulla is the next section. Now, within the medulla, we have our renal pyramids and our renal columns. This is a column, this is a pyramid. We also have calyxes, which are picking up urine. They're collecting things, collecting urine. Minor calyx, major calyx goes into the renal pelvis, then the urine goes into the ureter. And here's your artery and vein. Okay, the circulation. We start off with the aorta and then goes into the renal artery, and it goes into the interlobar arteries here, the arcuate arteries, cortical radiate arteries, cortical radiate veins, interlobar, I left out interlobar artery here, sorry, interlobar veins, segmental arteries. Eventually we have our renal vein. Okay, before you can understand renal function, you have to review a few little processes. The first is osmosis. This is the movement of water towards an area of high water concentration to an area of low water concentration. So when you have high water concentration, you have less stuff. That's your stuff. And the stuff can be, it says sugar here, but in the bloodstream, probably one of the major factors that keeps osmotic movement going from the kidneys back into the bloodstream is plasma proteins. And these would be your plasma proteins. And so basically when water is sucked towards those proteins. Okay, filtration. Filter is movement of a liquid through a pore, leaving the big chunks behind and making a substance in the end. Now, of course, this is the most wonderful beverage we all know of, but in the kidneys, rather than having gravity as the pressure that forces the water through the filter, we have blood pressure. Now, one more principle. When you have water flowing freely like this, it just has a nice big flow. If you narrow your tube, you end up with a much higher pressure flow. Those three things are necessary to understand how the kidney works. Okay, a nephron is a structural and functional unit that forms urine, and there's about 1 million per kidney, so they're microscopically tiny. It's made up of the glomerulus, which is a tuft of little fenestrated capillaries. Fenestration is, of course, has holes in it. And it has a renal tubule. It starts as a glomerular capsule or Bowman's capsule surrounding the glomerulus. So we have our little capillaries here, and incoming blood, outgoing blood, and it's surrounded by a little cup type thing here. And it goes out into a tube. Okay, and here we have a much better drawing than I can do. This is the afferent arteriole. The blood is going into the nephron. And this is the efferent arteriole. Blood is coming out of the nephron. This is your Bowman capsule here. And it goes through a series of tubules. And we'll have to come back, pick up what happens to this blood in the efferent arteriole before it makes any sense. But this is your filtrate. Basically, high pressure pushes stuff through here. The next picture may show better. Afferent is incoming. So high force, and it's higher and higher force because we got smaller and smaller arteries, pushes blood in. It pushes most of the juice out. And blood cells, plasma proteins, big stuff stays behind. So in our efferent arteriole, we have essentially sludge blood. Now, the efferent arteriole goes on to become a tubular capillary that sits next to the tubules. Let's look at the tubules first. Proximal convoluted tubule is the first tubule that comes off of the glomerulus and the Henle. It's just a loop, descending first, which is thin, freely permeable to water, thick, less permeable to water. And then distal convoluted tubule. Convoluted means twisty-turny. And that's the last part of your tubule. And then receive filtrate from the nephrons, fused together through papillae to form minor calyxes, which go into major calyxes, which go into the renal pelvis. Okay, now, while we're looking, we got two types of nephrons. Cortical nephrons hang out in the cortex, and that's most of them, 85%. Juxtamedullary nephrons, long loops of Henles that go down, they go down into the medulla. And these are important for concentrating urine. So this is that complex picture you all love to hate, and it's a little bit small to see what's really going on. But this is the cortical nephron, because the majority of it's in the cortex. This is the juxtamedullary nephron. because the majority of it, a big bunch of it, goes down into the medulla. Now, the glomerulus has afferent arteriole coming into the actual glomerulus, goes out into the efferent arteriole, and it's your filter. And this is showing afferent, efferent, and close-up of little fenestrations in the actual capillary. And then they're reinforced with these podocytes that keep them from just rupturing open. This is your tubule. Now, what's going to happen for this to make sense is your efferent arteriole. Let's see, I'm in blue here. This will be our sludge blood. This is coming from here. Is going to sit side by side. I'll change colors here for a second. With the proximal convoluted tubule, this. So they're going to sit side by side. So we have the sludge blood from the efferent arteriole here. We have the proximal convoluted tubule here. So you have high concentration, low concentration. So water gets sucked back into here. Because this actually, when it filters out the water, glucose, just almost everything. And you have to get it back into the bloodstream. The filtration membrane, water, small solutes, and we also have negatively charged base membranes that keep the large things in. And to make a long story short, the big stuff stays in the bloodstream. Big stuff being our plasma proteins. Okay, now, peritubular capillaries cling to the renal tubules, and then they end up emptying into venules. Actually, the kidney is one of the few places where you have an incoming artery and an outgoing artery. So these are the peritubular capillaries. Okay, so efferent and vasorecta is just a long version of the peritubular capillary, and it comes from the arterioles, efferent arterioles. Here we have a long loop of Henle, and these, at this point, we're calling our efferent arterioles. It then become, trying to find a picture of it, our peritubular capillary. There it is, right there. Our peritubular capillaries on this side are called vasorecta just because they're so long. Now, we already talked about juxtaglomerular nephrons. Those are just the nephrons that go outside of the cortex, but this is a juxtaglomerular apparatus. Each nephron has one, and they regulate the filtrate formation and blood pressure. And this is showing you what it is. This you have on each, this is your nephron. Afferent arteriole, efferent arteriole. I need to change colors again. There. And the macula densa cells right here that are picking up, and they measure the amount of salt, sodium chloride. And then you have granular cells right here that sense blood pressure. And so they regulate the rate of filtration depending on the pressure and the sodium concentration. Now, the kidneys filter the blood plasma about 60 times a day. And the filtrate is the blood plasma minus the protein. So almost everything gets put out into the filtrate. Urine is only 1% of the total filtrate. You take back almost everything that you filtered out. And then, but the urine contains what you want to get rid of in the first place, which are metabolic waste and things that you don't need. Okay, so the 3 steps of urine formation: glomerular filtration. You're putting the blood through the filter, and we're going to line up our afferent arteriole, which becomes a peritubular capillary, with the tubule, the little loops of Henle, and the blood is going to, the water is going to suck into the arteriole to concentrate it. That's your tubular resorption. Water, salt, glucose, amino acids, and a lot of stuff are pulled back into the bloodstream. Tubular secretion, you selectively put things back into the urine by active transport. Okay, the things that are the pressures, the forces that allow these processes to happen. Filtration, glomerular filtration, is hydrostatic pressure or blood pressure. Reabsorption is osmosis. Tubular secretion is active transport. This is just a review of the whole thing. Here's your afferent arteriole. The blood is filtered out, and you have sludge blood here in your efferent arteriole. And then this is going to be blood going into your filtrate. So this is very watery here, sludge blood here. And because you have the sludge blood, I guess that may not be the best term for it, but I like it. You're going to get osmosis, which is, I'm trying to say, they don't have, here's your filtration is number 1. 2 is your osmosis, going the water and a whole lot of other stuff comes back in. Then anything that got put back in you didn't want gets put back out by tubular secretion. This could be stuff like, say if you had too much potassium in your bloodstream, you could kick it back out by secretion. Okay, control of kidney function, sympathetic nervous system. If you're just rocking along in parasympathetic mode, the kidneys work really well. But if you're stressed, the kidney function is inhibited. Okay, now, renin-angiotensin II mechanism, the renin-angiotensin system. Okay, angiotensin is just it's a protein that floats around in your bloodstream. Renin comes in here, causes angiotensin I to be converted, an angiotensin converting enzyme, into angiotensin II. Angiotensin II causes arterial smooth muscle to constrict, so mean arterial pressure, so your blood pressure rises, stimulates resorption of sodium, triggers the adrenal cortex to release aldosterone, stimulates the hypothalamus to release antidiuretic hormone, and also makes you thirsty. Angiotensin II constricts efferent arterioles and increases fluid resorption, causes glomerular mesangial cells to contract, decreasing filtration. What actually, the summary, angiotensin II raises your blood pressure by causing vasoconstriction and fluid retention. Tubular resorption is a selective process. All the organic nutrients are reabsorbed, water and ions are reabsorbed. Some of this is hormonally regulated. Sodium is the most abundant cation in the renal filtrate, and active transport out of the tubule cell is a major way that you have sodium resorption. Okay, sodium resorption also brings other things along with it. Secondary active transport, organic nutrients. Okay, water is resorbed by osmosis, and then cations, fat-soluble substances are followed by diffusion. In the proximal convoluted tubule, you have most of the site of reabsorption. So first we had our afferent arteriole, and then we had our Bowman's capsule. Here's our Bowman's capsule. Here's our capillary efferent arteriole, and then the Bowman's capsule you take off here. The first tube off the branch is your proximal convoluted tubule. Convoluted means twisty-turny, probably not, look more like they're hemorrhoidal, but we'll be all right. Okay, I better erase them. So 65% of the sodium in water is resorbed in proximal convoluted tubule. Nutrients, ions, small proteins that got away are resorbed. Loop of Henle, in the descending loop of Henle, water is resorbed. Ascending loop of Henle, sodium, potassium, chloride ions are resorbed. In the distal convoluted tubule and collecting duct, resorption of stuff is hormonally regulated. Calcium, depending on parathyroid hormone, water, depending on antidiuretic hormone. Sodium resorption takes place because of aldosterone and atrial natriuretic peptide. Now, tubular secretion, we're getting active transport back into the filtrate. Potassium, hydrogen, ammonium, creatinine that happen to escape and get put into the bloodstream. Organic acids that you don't need anymore. Stuff that's bound to plasma proteins. This is where you get caught on those funny cigarettes that people smoke. The substance in those funny cigarettes, the THC, is bound to plasma proteins, and it stays there for quite a while, and then when you get drug tested, you get busted. So don't do drugs. Okay, tubular secretion eliminates stuff that have been passively resorbed, like any urea and uric acid, excessive potassium, and also controls the pH of the bloodstream. If it's too acid, you kick out acid. If it's too alkaline, you kick out base, bicarb. Diuretics are chemicals that enhance urinary output. Osmotic diuretic is something that causes diuresis due to a high osmotic pressure. Classic example, a person who is diabetic. If you can keep your blood pressure relatively under control, you don't spill glucose at all. You should have zero glucose in the urine. But once it gets over about 200, more or less, it overwhelms the system, and the kidney can no longer get rid of all the blood glucose. So some will spill over into the urine, and then it takes water with it strictly through osmosis, and so it makes you pee more. And when you pee more, more thirsty. So you have the polyuria and the polydipsia. Antidiuretic hormone inhibitors, alcoholic beverages, keep you from resorbing sodium and water, and you go pee a whole lot. Caffeine can be a diuretic. Okay, physical characteristics of urine, clear, pale to deep yellow due to a chemical called urachrome. Drugs, vitamins, and diet can alter the color. Cloudy urine may indicate a urinary tract infection. And in your seniors, probably the first thing you're going to see in a urinary tract infection is altered state of mentation. So if your patient goes psycho, and they were normal yesterday, do a urinalysis, because a urinary tract infection, not only will it kill your patient, but it will make them completely crazy, and likely due to buildup of ammonia that came from the retention and the bacteria in the urine. Okay, odor, slightly aromatic when fresh. Develops ammonia upon standing, so if you don't flush, everyone's going to know it. May be altered by some drugs and by vegetables. You still like asparagus, I'll leave it at that. The pH, slightly acidic, about 6. It can range from 4.5 to 8. Different things can alter the pH. Diet, vomiting. If you vomit too much, you end up having, you throw up all your acid, so you're going to have to retain some acid back, so you may have a more alkaline urine. Urinary tract infections tend to cause a more alkaline urine. And an alkaline urine favors the formation of kidney stones, so it's not to be desired. Urinary, more acidic urine helps prevent kidney stones and infection, so it's actually desirable to have a more acidic urine. Specific gravity is how concentrated the urine is. You measure this, you can do a dipstick, but a spectrophotometer is the best way to do it. 1.001 to 1.035 for the human species. Our camels we looked at, I think they can go to 1.055, but you'll have to look that up if you want to call me out on it. Okay, chemical composition of urine, 95% water, 5% solutes. Nitrogenous waste. Now, when we say nitrogenous waste, we mean the nitrogen-containing products, byproducts, metabolism, generally protein metabolism. Urea, uric acid, creatinine. And when we check for BUN, that's your blood urea nitrogen. And your blood urea nitrogen is this. If it's not getting filtered out, that could be a sign of kidney failure. You also test for creatinine, and you can test for uric acid. Other solutes, sodium, potassium, phosphate, sulfate, calcium, magnesium, bicarb. Abnormally high concentrations of any of these could indicate some sort of pathology. Urine should have 0 glucose in it, 0, zilch, none. If it does, you need to test the blood sugar and you need to see what's going on because it's not normal. Okay, ureters take the urine from the kidneys to the urinary bladder. They are retroperitoneal and they in the base of the bladder through the posterior wall. As the bladder pressure increases, the distal ends of the ureters close, preventing backflow of urine. The ureters have 3 layers. Transitional epithelium lining. You remember transitional epithelium is big and poofy, and then when it gets pressure on it, it's squashed. So just your urinary bladder has the same thing. And then when the pressure is let off, it poofs back up. Smooth muscle muscularis that contracts in response to stretch in an outer adventitia with fibrous connective tissue. Renal calculi are kidney stones. They form in the renal pelvis. Calcium, magnesium, or uric acid are the most common kinds, but there have definitely been cases in dogs of Cipro forming stones. So they had a bladder infection. Their veterinarian gave them Cipro to treat bladder infection, and the little bacteria formed a little small, let's call it a snowball, for lack of a better word, to build the big snowball on. And the Cipro built on and built on and built on, and you had a kidney stone made out of Cipro, which is considering that ciprofloxacin seems to be the first drugs that physicians pull out when you have a urinary tract infection. They do so because it works. Larger stones can block the ureter, cause pressure and pain in the kidneys, and even destroy the kidney. They can be due to chronic bacterial infection, urine retention, if you're not emptying your bladder, high calcium in the bloodstream, high pH of urine. Okay, the urinary bladder is a muscular sac for temporary storage of urine. It's retroperitoneal. It's on the pelvic floor, posterior to the pubic symphysis. Males, the prostate gland surrounds the neck of the urinary bladder inferiorly. So in prostatitis in males, it can cause obstruction of the urination. In females, the urinary bladder is anterior to the vagina and uterus. Okay, the trigone area is an area, I don't have a picture of it right here. I think I do in a couple of pages here. Yeah, I do right. Trigone area right here. They call it that because it's triangular. Here are your 2 ureters coming in, and this is where your urethra goes out. So it's called the trigone area, and it is very susceptible to keeping infections. If one has a urinary tract infection and it persists, that's a likely spot. Okay, layers of epithelium, the same old marshmallowy big poofy cells that squash. when they get pressure on them. The thick detrusor muscle, and it's in 3 layers, and then a fibrous adventitia. Actually, peritoneum is on the superior surface of the urinary bladder. Urinary bladder collapses when empty and forms rugae or ridges, and it expands and rises superiorly during filling without significant rise in internal pressure to a point. Okay, here we have peritoneum here, and then just adventitia down here. This is a ureter. Here's where your ureter comes in, right here, right here. This is a urethra. This is the external urethral sphincter here, and we have an internal urethral sphincter. So this one is involuntary, this one is voluntary, and this is obviously a female because of the short urethra. Now the urethra is a muscular tube. The line is mostly pseudostratified columnar epithelium, but near the bladder we have transitional. Near the external orifice we have stratified squamous epithelium, because anywhere one gets friction, one could have stratified squamous epithelium. Okay, sphincters. The internal urethral sphincter is involuntary. It contracts to open. The external urethral sphincter actually contract to hold the urine in and relax to let it out. It's voluntary, skeletal muscle, and the next slide here. Female urethra only 3 to 4 centimeters long, bound to the anterior vaginal wall. The external urethral orifice is anterior to the vaginal opening and posterior to the clitoris. I don't have a good shot of that right here, but okay, the male urethra carries semen and urine, but not at the same time, because urine is toxic to semen. 3 named regions. The prostatic urethra is within the prostate gland. The membranous urethra passes through the urogenital diaphragm, and then the spongy urethra is in the penis. You see it says 15 centimeters, and it obviously changes sizes depending on what's going on. Here's your prostatic urethra. This is your prostate gland. It goes completely surrounds this urethra. This is a membranous urethra right here. This is the spongy urethra right here. Okay, micturition is urination, the act of voiding. It requires 3 simultaneous events: contraction of the detrusor muscle by the autonomic nervous system, opening of the internal urethral sphincter by the autonomic nervous system, opening of the external urethral sphincter by the somatic or voluntary nervous system. The ability to totally control urination is not possible until between ages 3 and 4. Now, some children are pretty well potty trained at 2. I think it's ridiculous to have potty trained when they're 4 and 5, especially 5. I don't think they'll let them go to school if they're not potty trained. But the reason this is mentioned is because if you try to force your kids to be potty trained when they're a year old or 18 months, all you're going to do is cause psychological problems, especially if you're harsh and scold them and scare them. Okay, developmental aspects: frequent micturition or urination in infants due to small bladders, and they can't concentrate their urine as much. They live on liquid diets. Incontinence is normal in infants. They pee all over you and in diapers. The control of the voluntary urethral sphincter develops with the nervous system. Okay, this is another subject actually. E. coli bacteria account for 80% of all the urinary tract infections. And the E. coli comes from the digestive tract. It's normal flora in the digestive tract, an infectious agent in the urinary tract. And females are much more susceptible to urinary tract infections simply because of the short length of the urethra. Now, strep infections that are filtered out in the kidneys, you can get an immune response and cause long-term renal damage and even, renal death. Sexually transmitted diseases can also inflame the urinary tract. They're not limited to the non-urinary tract. And when you think about males, I mean, the urinary system and the reproductive system are really, really closely related. Well, they are in both sexes. So that covers it for the renal system. And if you have any questions, feel free to write me a note. That's it.